The PSA test saved Michael's life. That's what his family believed for 8 years. Annual screenings, biopsies every 18 months, radiation at 72 that left him incontinent and impotent. Then I opened his medical file during a second opinion consultation. The cancer they'd been treating? Slow growing, non-aggressive. Statistical likelihood it would ever cause symptoms in his lifetime? Less than 5%. Michael died at 80 from a hospital-acquired infection during his 4th round of treatment. Not from cancer, from the treatment of a disease that was never going to kill him. Here's what nobody tells you. After 65, some screenings cross a line. They stop preventing disease and start creating patients. That gap between what gets recommended and what the evidence actually supports. That's where I've watched too many lives get shorter instead of longer. I'm a cardiothoracic surgeon, 28 years, over 2,000 operations. I've held beating hearts in my hands, and I've sat in hospital cafeterias at 3 in the morning, reviewing charts of patients who didn't need to be there. You reach a point in this career where you stop believing the system always knows best, because I've seen the other side, the side where screening becomes a business model, where fear drives protocols, where doctors order tests, not because they help patients, but because they're trained to, because the guidelines say so, because nobody wants to be the one who didn't catch something. I'm not here to tell you to avoid your doctor. I'm here to tell you which screenings, after a certain age, carry risks that outweigh any potential benefit. The ones that turn healthy seniors into worried patients. The ones that lead to procedures that cause real harm while chasing shadows. Your body at 65 is not your body at 45. That sounds obvious, but medicine doesn't always act like it. Screening programs were designed around younger populations, faster-growing cancers, longer life expectancies where early detection changed outcomes. But after 65, biology shifts. Cancer growth rates slow. Competing health risks rise. A test that saves lives at 50 can shorten them at 75. Think of it like this. If you're standing in a building and someone yells fire, you run. But if that building is scheduled for demolition in 6 months anyway, and running means you might fall down the stairs and break your hip, suddenly running becomes the bigger danger. That's screening in older adults. The fire might be real but slow moving. The fall is immediate. One study in the Journal of the American Medical Association followed 14,000 seniors. Those screened aggressively after 70, higher rates of complications from follow-up procedures than cancer deaths prevented. We're not just talking statistics. We're talking real bodies, real consequences. Let me walk you through the 3 screenings you should question after 65. Stay with me, because each one has a mechanism you need to understand. First, PSA testing for prostate cancer. This test measures a protein in your blood. Elevated levels might indicate cancer, or an enlarged prostate, or an infection, or nothing at all. You get a high number, and suddenly you're in a urologist's office scheduling a biopsy. 12 to 18 needle punctures through the rectal wall into the prostate. Infection risk? 3 to 5%. Sepsis risk? 1%. Now you're taking fluoroquinolone antibiotics that carry their own risks. The biopsy comes back positive. Not surprising, by age 70, 60% of men have some prostate cancer cells. Most will never grow, never spread, never cause a single symptom. But now you know, and knowing changes everything. Your doctor presents options: surgery, radiation, hormone therapy. Each carries guaranteed side effects: incontinence, erectile dysfunction, bowel problems, fatigue. You're treating a disease that, in 80% of cases in men over 70, would never have announced itself. I had a patient named Richard, 71, active, hiking every weekend. PSA came back elevated during a routine physical. Biopsy, low-grade cancer. Gleason score 6. His urologist recommended radiation. Richard asked about active surveillance. Watchful waiting isn't really treatment, the urologist said. So Richard did the radiation. 6 weeks, 5 days a week. Within 3 months, he needed pads. Within 6 months, he couldn't maintain an erection, even with medication. He stopped hiking because he couldn't trust his bladder on the trail. 2 years later, a follow-up biopsy during a complication check. The cancer was still there. Same grade. Hadn't changed. Write that down. The treatment didn't eliminate the cancer, and it destroyed his quality of life. The U.S. Preventive Services Task Force gives PSA screening after 70 AD rating. That means the harms outweigh the benefits. The Canadian Task Force agrees. So does the European Association of Urology for men over 70 without symptoms. What should you do instead? If you're over 70 with no urinary symptoms, no family history of aggressive prostate cancer, and no discussion with your doctor about your individual risk factors and values, skip the PSA test. If you're between 65 and 70, have that conversation first. Understand that finding cancer isn't the same as preventing death. Starting tonight, if your doctor orders a PSA as part of a routine panel, ask one question. What will we do differently based on this result? And is that action proven to help men my age live longer or better? Second, annual mammograms after 75. Breast cancer screening saves lives in women aged 50 to 69. The evidence is solid, but after 75, the picture changes. Screening finds cancers, yes, but it also finds a lot of DCIS, ductal carcinoma in situ, stage 0, cells that look abnormal under a microscope but haven't invaded surrounding tissue. Some DCIS will progress to invasive cancer, some won't. We can't tell the difference, so we treat them all. Lumpectomy or mastectomy, radiation, sometimes hormone therapy for 5 to 10 years. I've reviewed cases where women in their 80s underwent surgery for DCIS, developed surgical site infections, spent weeks in recovery, only to die 3 years later from heart failure, the condition they had before the cancer diagnosis. The cancer never progressed. The treatment shortened what time they had left. Here's the mechanism you need to understand. Breast cancer grows slower as you age. A cancer detected at 78 might take 10 to 15 years to become life-threatening. If your life expectancy based on other health conditions is 7 years, you're treating a disease that won't outlive you. But here's what makes this complicated. The medical system doesn't think in those terms. You get a call back after a mammogram. We saw something. Now you're in for a second mammogram, then an ultrasound, then a biopsy. The biopsy shows DCIS. Your surgeon says, "We caught it early." You're lucky. Are you? A woman named Dorothy, 79. Mild heart failure, well-controlled diabetes, living independently. Routine mammogram found DCIS. She had surgery. Developed a post-operative infection that required IV antibiotics. The antibiotics stressed her kidneys. Her heart failure worsened during recovery. She never quite got back to baseline. Gave up her volunteer work. Stopped driving. Moved to assisted living within a year. The DCIS, post-surgical pathology showed it was low-grade, estrogen receptor positive, slow-growing. Her oncologist later admitted, off the record, that in a woman her age, watchful waiting might have been reasonable. But that conversation never happened before the surgery. The American Cancer Society updated their guidelines. For women 75 and older, they recommend discussing whether to continue screening based on overall health and life expectancy. The key word is discussing, not automatically scheduling. Here's your move. If you're over 75 before your next mammogram, ask your doctor to estimate your life expectancy based on your overall health. If it's under 10 years, ask what benefit screening provides. If you're between 70 and 75 with other significant health conditions, have the same conversation. You're not refusing care. You're refusing unnecessary harm. Now let me tell you something I don't share often. I've stood in operating rooms where the person on the table didn't need to be there, not because of malpractice, not because of incompetence, because the system has momentum. A screening finds something. The finding triggers a protocol. The protocol leads to a procedure. And nobody along that chain stops to ask whether this particular patient, at this particular age, with this particular health profile, actually benefits. I've sat with families in waiting rooms who believed they were doing the right thing. We caught it early, they'd say, relieved. And I couldn't tell them that early detection isn't always good detection. That sometimes the bravest thing you can do is leave something alone. Those conversations haunt me because the outcomes were predictable. We created the complications, we shortened the lives, and the patients trusted us. Third, colonoscopy after 75. Colorectal cancer screening works. It finds polyps before they become cancer. It detects early-stage disease when treatment is effective. But colonoscopy isn't a gentle procedure. You're sedated. A scope is threaded through your entire colon. Biopsies are taken. Polyps are removed. The preparation alone, hours of bowel purge with powerful laxatives, stresses your system. Dehydration risk, electrolyte imbalances. For older adults with kidney disease or heart conditions, that prep can trigger serious complications. The procedure itself carries risks that increase with age. Perforation, a tear in the colon wall, occurs in 1 out of every 1,000 colonoscopies. Doesn't sound like much until you're the one. Perforation means emergency surgery, possible colostomy. Weeks of recovery, infection risk. For someone 78 years old, that complication can cascade. Now add this, colorectal cancer develops slowly. A polyp takes 10 to 15 years to become cancer. If you're 78 and your last colonoscopy at 68 was clear, what are you screening for? A cancer that won't have time to kill you. I had a patient named Frank, 76. Cardiologist recommended a colonoscopy because it had been 10 years. Frank had chronic kidney disease, stage 3. The bowel prep tanked his kidney function. He became acutely dehydrated. His creatinine spiked. He ended up hospitalized for 4 days. The colonoscopy found 1 small polyp. Benign. Hyperplastic, zero cancer risk. Frank's kidney function never fully recovered. He's now stage 4, closer to dialysis, because we looked for a problem that wasn't there. The U.S. Preventive Services Task Force says adults aged 76 to 85 should only continue screening if they've never been screened before or if prior screenings showed high-risk findings. After 85, they recommend stopping entirely. The harms outweigh any possible benefit, but I still see colonoscopies scheduled routinely for seniors in their 80s. Why? Because stopping feels like giving up. Because doctors worry about missing something. Because patients have been told for decades that screening saves lives, and it's hard to hear that the advice has an expiration date. Your action here. If you're over 75 with no history of polyps or colon cancer, no family history, and no symptoms like rectal bleeding or unexplained weight loss, you can stop screening. If you're between 70 and 75, talk to your doctor about whether your individual risk justifies continuing. If you have other serious health conditions that limit your life expectancy, screening makes even less sense. It is never too late to stop doing things that don't help you. Michael's daughter called me 6 months after he died. She'd found the medical records, read the pathology reports, understood finally what had happened. Why didn't anyone tell us we had a choice? She asked. That question has stayed with me, because we do have a choice, but the system doesn't present it that way. Screening gets framed as responsible. Declining it gets framed as denial. The truth lives somewhere in between. The truth is that your body at 70 is not a younger body failing. It's a different body with different risks and different timelines. The truth is that medicine designed for 40-year-olds doesn't always serve 80-year-olds. And the truth is that you have the right to ask what happens if you don't do the test. What changes? What stays the same? What risks you're actually avoiding versus what risks you're creating. Let me summarize the 3 screenings to reconsider after 65. 1. PSA testing for prostate cancer after 70, especially without symptoms or high risk factors, leads to overdiagnosis and treatments that cause guaranteed harm for uncertain benefit. 2. Annual mammograms after 75 detect slow-growing cancers and DCIS that may never threaten your life while exposing you to procedures and complications that definitely will. 3. Colonoscopy after 75, particularly if previous screenings were normal, carries risks that outweigh benefits when your life expectancy is limited by other conditions. These aren't recommendations to ignore your health. They're recommendations to protect it. Now I want to hear from you. Have you had a screening after 65 that led to treatments you now question? Or did you have a conversation with your doctor where you decided together to stop a test, and how did that decision work out? Leave a comment. Your experience might be exactly what someone else needs to hear. If this information gave you a framework you didn't have before, share this video with someone who's navigating these decisions. And if you want more content that questions medical protocols and puts your well-being first, subscribe to this channel. We're building a community that doesn't just accept what the system offers. We ask better questions. One more thing. I'm a surgeon, not your surgeon. This video presents information about medical screening practices and their risks based on current evidence and clinical guidelines. It is not personal medical advice. Before making any changes to your healthcare routine, including stopping or declining screenings, have a detailed conversation with your own physician who knows your complete medical history, your individual risk factors, and your health goals. Every person's situation is different. What I've shared here are principles to guide your questions, not decisions you should make without professional input. Your heart has been working for you every single minute of every day since before you were born. It deserves decisions made with both evidence and wisdom. Be well.